Today, we're going to discuss anesthesia procedures, methods, and techniques, a potpourri of anesthetic issues that you may face when undertaking the ABA examinations. And what about the stages of awareness? A score of 3 on our next question on the Modified Observer Assessment of Alertness Sedation Scale, known as MOAS, suggests that a patient undergoing sedation will respond how? A, lethargic response to his name spoken in a normal tone. B, responds only after name is called out loudly and repeatedly. C, responds only after mild prodding or shaking. And D, responds only after painful trapezius squeeze. This is under sedation. And the answer is responds only after his name is called out repeatedly or loudly. And here's the MOAS scale. And the MOAS scale is similar to another scale known as the Ramsey scale, which has been around for 30 or 40 years, an assessment of the depth of anesthesia, particularly applied to sedation. And we can see here the scale from 5 to 0, where 0 is no response to painful trapezius squeeze. It's interesting that the MOAS scale has correlated well of late with the BIS in studies, and so it is a worthy scale to incorporate in the sedation unit. Now, what about the inhalational agents? And the MAC of an inhalational agent required to prevent movement in 100% of patients is greatest for which of the following noxious stimuli? A, laryngoscopy, B, rib retraction, C, abdominal incision and exploration, and D, electrical tetany. The correct answer is laryngoscopy. And these are data from 20 years ago, but Zbidin looked at a variety of stimuli, and just to summarize for you, L is laryngoscopy, S is squeezing the trapezius, T is tetanus, SI is skin incision, and I is intubation. And you can see in the first item in the legend, the L, which is the dark orange, that the greatest anesthetic concentration is achieved at about 2.4%, which is for laryngoscopy. So what are the stages of anesthesia and awareness, and how do you answer questions on these subjects? Awareness is specifically the postoperative recall of events occurring during general anesthesia. Something happened during the surgery, and you recall the events, and you can repeat exactly what happened. Amnestic wakefulness is a responsiveness during general anesthesia without postoperative recall. So they did respond, but they don't remember that they responded. Dreaming is any experience, excluding awareness, that patients are able to recall postoperatively that they think occurred during general anesthesia, and that they believe is dreaming. And that's into the fuzzy zone of recall. Explicit and implicit memory are two assessments of recall. Explicit memory is conscious recollection of previous events, and that is you can repeat what you heard or saw or felt exactly as it occurred during the time, without any prompting, without demonstrating or showing any stimulation to prompt that recall. Implicit memory, however, is a change in behavior or performance that is produced by the previous experiences without conscious recall at the time. And that is different. Implicit recall may, for example, when we tell a patient the name of a food before they go to sleep, and after the surgery ask them if we told them the name of the food, and they say no. No explicit recall. But let's say all the foods began with the letter A, and we show them the letter A and say, name a food. And that, showing the letter A, stimulates some subconscious recall, and they will say a food with the letter A that happens to be the name of the food that we told them preoperatively. So they don't remember us telling them explicitly the name of the food, but when prompted with just the first letter, the first food that comes to mind happens to be the name of the food we told them. That's implicit memory. And so to test recall, there are 4 questions that comprise the Bryce questionnaire. Abuelish and Taylor modified the Bryce questionnaire to form some commonly used questions for recall after anesthesia. For example, what was the last thing you remember before going to sleep? What was the first thing you remembered upon awakening? Do you remember anything between going to sleep and awakening? And while you were asleep, did you dream? So patients should be questioned, however, more than once postoperatively to maximize the likelihood of all cases of awareness. And clinicians should note that the modified Bryce questionnaire has been administered to tens of thousands in the quality assurance audits and research projects without stress to the patients, making it a very useful tool. And that leads us to the utility of the BIS in preventing awareness. As a monitor, concurrently with administering anesthetic, it's been evaluated in 3 large studies. And let's see what they found. Ekman and colleagues conducted a huge Swedish study undergoing non-cardiac surgery with muscle relaxant, general anesthesia, and BIS monitoring. They interviewed the patients 3 times with a modified BIS questionnaire, and the incidence of awareness was significantly reduced in the BIS group compared to historical controls. So the utility of the BIS in preventing awareness seems to have been reasonably well documented. Miles and co-authors had a multi-center randomized controlled trial, much better than the first study, in patients at risk for awareness undergoing all types of surgery. It's called the Be Aware trial, and they were randomized to the BIS or not the BIS. And they were interviewed 3 times, modified Bryce questionnaire. The overall incidence of awareness was 0.5%. However, they had 2 cases of awareness in the BIS group and 11 in the control group, a 5-fold reduction in the incidence of awareness when the BIS was used and maintained between 40 and 60. Awareness was not predicted from any of the clinical signs that occurred during the case. The authors concluded that the BIS monitoring was warranted in high-risk patients. Avedon took this investigation one step further, and he conducted a randomized trial. But in his trial, or their trial, they compared BIS-guided anesthesia to end-tidal gas anesthesia, where at least 0.7 MAC of inhalation agent was administered at all times. And two were interviewed in a standard manner with an overall incidence of awareness of only 0.2%. So that's 2 in 1,000 patients. And there were 2 cases of awareness in each group. The authors concluded that their results did not support BIS monitoring. In fact, you could achieve the same thing with end-tidal monitoring. But there's a suggestion or criticism that this study was actually underpowered. But the conclusion to walk away from is that end-tidal gas monitoring may be as effective as the BIS, and so it is behooves us to monitor the end-tidal concentrations if you're not using the BIS. The issue is that we don't have low-level concentration alarms on our anesthetic machines, and so it is possible, for example, to run out of inhalation agent and not realize it. And so that needs, or the monitors are turned off, and both of those need to be established. For that matter, we also don't have alarms on the BIS monitor to indicate that the BIS is reading 80. The final decision of the ASA task force at the time was that the decision to use a brain monitor should be made on a case-by-case basis by the individual practitioner for selected patients. Our next question. Dreaming during general anesthesia is least likely with which of the following maintenance techniques? Propofol infusion, B, propofol and ketamine infusions, C, isoflurane and ketamine infusion, and D, fentanyl, midazolam and ketamine infusions. It is least likely with isoflurane and ketamine infusion. So dreaming during anesthesia is commonly reported and fascinating, in part because it is very poorly understood. It varies with age and sex, type of anesthesia, and the timing of the interview. Dreaming is more common in younger patients and after a propofol-based, opioid-based, or ketamine-based anesthetic. If the interview is conducted at emergence, about 25% of the patients will report dreaming. However, if the interview is delayed until discharge from the PACU, the incidence drops to about 6%. So it is not a phenomena that is retained long term.